Spillover effects. Multiple studies have found that higher increases in Medicare Advantage penetration in a county is associated with lower traditional Medicare spending per enrollee, implying some sort of spillover effects. A 2013 study found that having more seniors in Advantage's managed care is associated with reduced hospital costs for all seniors and for younger people commercially insured, meaning it lowered costs for people not even in managed care. It was not associated with fewer hospitalizations, but associated with lower cost and shorter stays per hospitalization. The authors estimate that 10% of increased payments from the government to Advantage are made up for by lower traditional hospital costs. The hospitals themselves may capture a lot of these savings rather than traditional Medicare itself, but that's partially because of how traditional pays hospitals. Of course, this implies that the other 90% of that increased cost is not made up for, but still, this and other studies find evidence for spillover effects. A 2020 study found that after controlling for health status and other variables, a 1 percentage point increase in a county's Advantage penetration causes a 0.7% reduction in standardized traditional spending per enrollee. The researchers found evidence of less utilization across different types of services. A 2023 study found that the more Advantage penetration there is in a market, the less traditional Medicare enrollees used post-acute care, and there wasn't a corresponding increase in hospital readmissions. Why might these correlations be caused by more people on Advantage? A mechanism is managed care influencing physician practice styles, not only for managed care patients, but for all patients. Having many managed care patients could change the norms of how physicians operate or their standard way of operating. Another mechanism is managed care influencing healthcare investment and technology adoption. If managed care reduced the number of MRI machines, this could reduce the number of MRIs performed, period. Several studies have shown that managed care can affect the use of high-cost procedures by way of affecting hospital infrastructure. If providers have multiple payers, and if they have trouble adjusting their quality between purchasers, then the demands of a major purchaser can have spillover effects on the patients of other purchasers. Advantage penetration could also potentially induce more care. For example, if managed care patients use less services, this reduces demand, lowering prices, and potentially induces more use by people not in managed care. If physicians want a specific income, then income they lose from Advantage plans, they may try to make up by seeing more patients or increasing prices on non-Advantage patients. That 2020 study estimated that for each 1 percentage point increase in a county's Advantage penetration, there is a $64 reduction in traditional Medicare spending per enrollee. If that applied to all 19.7 million people enrolled in traditional Medicare in 2020, that would be a savings of $1.9 billion. This may sound like a great argument for Advantage, but each Advantage enrollee costs the taxpayer a few hundred to well over 1,000 more than a traditional enrollee. This adds up to increased costs many times over that $1.9 billion. Furthermore, the overpayment of Advantage is more straightforward than estimating the spillover effects, meaning we can be more confident in the numbers. So even after taking into account potential positive spillover effects, Medicare Advantage costs taxpayers a lot more than if Advantage didn't exist. Medicare Advantage taking advantage of healthier seniors and switchers. One notable issue with Advantage is people signing up for Advantage, paying those low rates, and then switching to traditional Medicare when they get a costly illness. This means, for these cases, Advantage plans take in all the customer premiums, take in the massively overpaid government payment, and then don't even pay for medical care. Advantage plans save money by maintaining limited networks and denying coverage, and if they do not cover the doctor, facility, or procedures that one needs for their ailment, people switch to traditional so that the taxpayer can pick up most of the bill. That this happens shows the inadequacy of Advantage coverage and means the costs of Advantage are even higher than they seem. Estimates that show how much the taxpayer overpays Advantage do not include that some of the traditional spending is from people who had been sitting in Advantage plans for years. In other words, people take advantage of cheap premiums, then move to traditional Medicare when they need to use a specific doctor or treatment, billing the taxpayer for it, and then sometimes go back to Advantage. In these situations, insurance companies are not even really doing their job. They get that payment from the government instead of the government paying directly for healthcare, so that if someone needs medical help, the insurance companies pay for it. But in this scenario, they get the federal payment for years, then the patient still uses government money to pay for medical care by switching to traditional. In these cases, the insurance companies and such patients are ripping off the taxpayer and damaging the long-run sustainability of Medicare. A 2019 KFF analysis saw that during their most recent year on traditional Medicare, people who switched from traditional to Advantage spent 13% less than those who did not switch. Likewise, those that switched from Advantage to traditional had higher risk-adjusted spending than those who remained in Advantage, meaning, on average, people who need to use more medical care tend to switch to traditional, and people that don't need to use as much medical care tend to switch to Advantage. These numbers were found after adjusting for risk. So this study showed that even after risk scores were implemented, there was costliness not being captured by those scores, and this means the real difference is even larger. A 2019 JAMA internal medicine study saw patients with multiple chronic conditions switch to traditional Medicare at higher rates than other patients. A 2015 study saw patients that used high-cost services more likely to switch to traditional Medicare. From 2007 to 2014, between 9 and 11% of Advantage enrollees voluntarily switched plans each year. Each year, 2% of Medicare Advantage enrollees switched from Advantage to traditional. A study found that patients have a 37% greater chance of switching from Advantage to traditional after a cancer diagnosis, and a 29% less chance of switching from traditional to Advantage after a cancer diagnosis. A 2019 study found that of high-need enrollees, 4.6% of Medicare only and 14.8% of Medicare Medicaid beneficiaries who were enrolled in Advantage plans switched to traditional Medicare compared to 3.3% and 4.6% of non-high-need Advantage enrollees. The difference between high need and low need indicate that Advantage is more likely to not cover the needs of high-need individuals, so they switched to traditional. That more switch among Medicaid enrollees, meaning they have less need of a Medigap policy, indicates that others may have switched if not for higher Medigap costs for those who switched with pre-existing conditions. Among high-quality Advantage plans, high-need enrollees also switched more than non-high-need enrollees, 4.9% and 11.3% compared to 1.8% and 2.4%. A 2021 Government Accountability Office analysis talked about an out-of-the-ordinary number of people switching from Advantage plans to traditional Medicare in their last year of life, questioning whether those people were able to get timely needed care before passing. The end-of-life moves from Advantage to traditional costed Medicare hundreds of millions of dollars. Some studies suggest that people temporarily switch to traditional Medicare, get healthcare not covered by Advantage plans, then switch back to Advantage. Newer rules have attempted to make this harder. Still, even new studies find this. A 2020 study found that Advantage enrollees with Alzheimer's and other dementias disenrolled from Advantage at higher rates than those without those conditions, indicating that Advantage plans were not providing appropriate care for those people. One study found that over half of people who disenrolled from Advantage plans re-enrolled within 12 months. This could be because they wanted a procedure by an out-of-network provider, so switched to traditional Medicare, got the procedure, then went back on their cheap premium Advantage plan. A 2023 study found that before 2015, beneficiaries with multiple chronic conditions were more likely to switch from Advantage to traditional, but the study found that after 2015, at least through 2019, that was no longer true. They suggest the risk-adjusted payments may have incentivized Advantage plans to be better for people with multiple chronic conditions. Unfortunately, if true, this would mean the taxpayer may have had to way overpay Advantage plans just to make their plans workable for many people with chronic conditions. Historically, Advantage enrolled more lower-income people, but its enrollment of wealthier people has increased. This could cause better benefits and more comprehensive coverage. Compared to Advantage enrollees who did not switch, enrollees who switched from Advantage to traditional are more likely to be duly eligible for Medicare and Medicaid, to live in rural areas, to live in counties with fewer and lower-rated Advantage plans, to have bad health, to need more help with daily living, and to use healthcare more. Advantage rural enrollees have been twice as likely to switch to traditional Medicare. Among rural Advantage enrollees, dissatisfaction with care access has been associated with switching to traditional from Advantage. Rural enrollees were not sicker, nor did they have higher need. So the rural problems seem to be caused by rural areas having narrow networks than non-rural areas and less providers and plans in the first place. A study found that people who switched from traditional Medicare to Medicare Advantage had lower risk score adjusted expenditures the year they decided to switch than people who did not switch. For all 14 years studied, 2006 to 2019, the chances of someone switching to Advantage were higher for someone with lower risk score adjusted spending, with the chance of switching shrinking as spend went up. A 2019 study found that beneficiaries who had a new diagnosis of Alzheimer's and related dementias, hypertension, or psychiatric disorders had a higher chance of switching to Advantage and a lower chance of leaving Advantage. This evidence goes against the general trend of costly diseases making someone more likely to leave Advantage for traditional. The proportion of beneficiaries who switch from Medicare types isn't huge, less than 10%, but they are important for several reasons. Switchers are not only yet another way by which Advantage is ripping off the taxpayer. Studying them reveals other problems with the program. They show that the risk scores are not capturing a lot of risk. They show that Advantage plans often do not sufficiently cover complex and costly illnesses. They show that Advantage plans are especially weak in rural areas. Switchers are yet further evidence that Advantage has favorable selection problems. They show that people may not be getting what they expected when they sign up for an Advantage plan. They show that people are willing to manipulate the system to save them money at the taxpayer's expense. They show the importance of some sort of supplemental coverage like Medicaid or Medigap. We already knew these things from anecdotes, expert testimony, and studying more general data, but switchers are a good test case where we can look at the differences between those who switch and those who don't. That these studies line up with other methods of researching the topic that also point out some major problems with Medicare Advantage should make us more confident in Advantage's problems. Health outcomes. What the health outcomes are. Most studies find similar health outcomes when comparing Advantage and traditional. Studies have found that Advantage is no better than traditional on mortality, readmission rates, and patient experience. Various studies find better outcomes on specific things for Advantage over traditional, including the outcome of reduced mortality, but it's not clear that Advantage is making that happen rather than this being the result of selection effects. A smaller number of studies find better outcomes in traditional. Many studies find no difference in outcomes. MedPAC could not conclusively say whether health outcomes were better under Medicare Advantage or traditional Medicare. More specifics on outcomes. Systematic reviews of studies that compare Advantage and traditional on outcomes and quality have mixed findings. Advantage enrollees get a little bit more breast cancer screening but are more likely to use worse nursing facilities and more likely to use worse home health agencies, while being less likely to use higher quality cancer centers and more likely to die after cancer surgery. One study found that those with Advantage at the time of a cancer diagnosis compared to traditional have an increased chance of death. The difference is most prominent in patients living near a prestigious cancer center or whose cancer most needs specialized care. A study found that Advantage enrollees who need complex cancer surgeries were less likely to be treated at specialized centers, had longer delays, and had higher mortality than people in traditional Medicare. A study looking at patients' self-reported experiences with post-acute care, like home health and skilled nursing facilities, found traditional Medicare enrollees to be more likely to have improvements. A study looking at patients going through chemotherapy found that Advantage uses less resources without negative health impacts. However, some of their health measures were not very good. They did look at survival and found no difference between the two, but if Advantage doesn't allow chemotherapy for those who have too advanced of cancer, then a similar survival actually indicates worse outcomes for Advantage. Advantage plans can provide teams to support care, and this may have led to less broken bones. A 2022 review of studies found only few differences between Advantage and traditional that are supported by strong evidence. People with Both Medicare types had similar satisfaction rates. Advantage had higher use of preventative services, had more enrollees with a usual source of care, and lower hospital readmission rates. Traditional gave more access to the highest rated hospitals for cancer care and the best skilled nursing facilities and home health agencies. Fewer traditional enrollees had a cost-related problem. This was mainly caused by low rates of cost-related problems of those with supplemental insurance. Although studies found Advantage enrollees used less post-acute care, the studies didn't find related associations with health outcomes. A 2021 review of studies found that people on Advantage had more preventative visits, fewer hospital admissions and emergency department visits, shorter skilled nursing facility and hospital stays, and less healthcare spending. Advantage did better on quality of care metrics. Neither Medicare version was better in patient experience, readmission rates, mortality, or racial/ethnic disparities. The study notes that the evidence may not fully take into account selection bias or risk adjustment difficulties, partly because the data quality from Advantage and traditional differs. A 2018 study, after controlling for clinical factors, demographic factors, and zip code, found that patients with traditional Medicare were more likely to enter high-quality skilled nursing facilities than those with Advantage, especially compared to those with lower-quality Advantage plans. A 2022 study found that Advantage enrollees had increased 30-day mortality for liver, pancreas, and/or stomach surgery. Studies that use administrative data to look at post-acute care and patient outcomes find that Advantage members use less post-acute care. A 2018 home health study found that Advantage enrollees were 30 times more likely to have just one home health visit compared to multiple visits for those in traditional Medicare. The studies did not find a difference in deaths or hospital readmissions. A 2023 study using self-reported data rather than administrative data found Advantage enrollees used less post-acute care with the shorter durations and found that fewer Advantage patients reported improving functioning during or after post-acute care. A 2021 study used instrumental variables to find that plans that spend more tend to reduce mortality. Quality ratings are not correlated with mortality. Good insurance greatly reduces mortality, and directing people to those plans could have health benefits. Determining whether the choice of Medicare type has a causal relationship with health outcomes is difficult due to data limitations and selection problems. We have better data for traditional because their bills go through the government. Data from the various Advantage plans is patchy, with some plans giving more data to researchers than others. However, Advantage data has been getting better recently. Why those outcomes? It's not clear whether we should have expected better health outcomes with Advantage or traditional. On one hand, considering the difficulties with narrow networks, prior authorizations, and the general incentive for private insurance companies to discourage expensive healthcare usage, you'd think that Medicare Advantage patients would have worse outcomes than traditional Medicare patients. With half of Advantage enrollees changing plans within 5 years, insurers may have less incentive to invest in preventative care and chronic disease management. Why spend money on reducing future costs when a different plan will pay for it? Also, switching plans may lead to discontinuities in care. The Advantage market is dominated by large for-profit health insurance companies whose ultimate goal is to maximize profit, not increase the health of its customers. It's possible that the best way to do this is to take as much taxpayer money as possible and limit the amount of healthcare spending as much as they can, essentially manipulating the system to maximize the amount taken in while minimizing the amount going out. It's not clear that this should lead to the best health outcomes. For insurance companies, it is best for you to be healthy for some years, then just die quickly so they don't have to pay for your long-term healthcare needs. The profit motive could produce incentives counter to the goals of keeping people financially secure and healthy. The purpose of traditional Medicare and Medicare in general is to provide healthcare coverage for seniors. The purpose of Medicare Advantage in the eyes of insurance companies is to make money. Making money in and of itself isn't evil. Making money in fair and competitive markets is what companies should do. But we should ask whether the public Medicare program is best served by profit-maximizing companies. And we should realize that Medicare Advantage companies don't compete in a normal market. They make their money by the government giving them a lump sum per enrollee, and then maximize their profits by minimizing what they pay in health services. In a properly competitive market where people understand the risks and benefits of different plans, this should result in a good outcome for beneficiaries. In a gameable government program, In a market dominated by large companies, selling a product that can be difficult to understand and impossible to predict one's need for its use, in a scenario where one's Medigap alternative gets considerably worse once a person chooses not to go with that option, it's plausible that private companies operating the Medicare program for profit may not lead to the best outcomes. On the other hand, with Medicare Advantage, we are supposed to have a system incentivized to responsibly improve care while also managing costs. Insurers try to use care coordination and planning to improve healthcare at an efficient cost. While coding every potential diagnosis helps Advantage plans make more money by higher risk scores, it also can be used to improve the care of patients. Advantage plans often have care teams that use this diagnosis information to help care for patients. Having all this information within one team allows providers and insurance care teams to get a total picture look at a patient's problems. This information can be used to determine healthcare needs and possibly facilitate innovation in delivering care. Traditional Medicare doesn't make an effort to record diagnoses or issues on top of what doctors record during visits. The hope is that Advantage helps identify patients in need and gets them cheaper care before they need more expensive care. Compared to traditional enrollees, Advantage enrollees are more likely to have a treatment plan, someone to review their prescription, and a regular doctor or place to get care. Having this attention and help may help beneficiaries get assistance and manage their conditions. We have too many anecdotes and reports from doctors telling us how Advantage has hurt patients to reject the harm Advantage does to some people. It's possible Advantage is a net negative on health, and this doesn't show up in the data because people who go into Advantage are healthier in the first place. It's very difficult to get around this selection problem. However, it's also plausible that the coordinated care that Advantage provides or incentivizes could improve people's health. So, some of the mixed findings may be due to this counteracting some of the negatives. In the end, the burden of evidence should be on Advantage. Advantage is costing the taxpayer more. It costs more even though one of its main points to existing is costing the taxpayer less. If it is going to fail one of its main mandates and cost more, then we should have clear evidence of health benefits from Advantage. We don't have that. Why do so many choose Advantage? One argument for the quality of Advantage plans is that so many people are choosing them. This does show that with current government overpayments, Advantage insurers are able to provide plans that are good enough to convince people to join. The problems with this argument are A. People may have made a mistake or not realize the quality of what they are getting, and B. Of course people like low premiums and extra benefits that are paid for by other people's taxes. Advantage plans are heavily marketed and advertised for. And as with marketing for any other product, the goal isn't to deliver the well-balanced truth to potential customers, but a positive spin to persuade people to buy a product. Advantage plans also use agents who are skilled salesmen. Advertisements often include celebrities, and marketers sometimes repeatedly call seniors to pressure them to switch to an Advantage plan. Between 2020 and 2021, there were 41,000 complaints about Medicare Advantage's marketing tactics. Seniors have been approached at grocery stores by insurance agents selling Advantage plans. At times, agents have said that a senior's doctor is covered, but then that turns out not to be true. Some mail marketing looks like official letters from the federal government, but are marketing schemes from an insurance company or an insurance salesman. At times, people have been called 20 times a day by agents. The use of the term Medicare in marketing may deceive seniors who think it is from the government rather than a private entity. Agents push Advantage over traditional with a supplemental because commissions are higher on Advantage. Brokers who sell insurance plans in 2024 were paid a commission between $611 and $762 for a first-year Advantage plan, and about half for annual renewals. By contrast, they get paid $300 on average for the first year of Medigap. Despite getting higher commissions for Advantage, when the Commonwealth Fund asked brokers which plan they would choose, they said traditional Medicare with Medigap because it offered more coverage and choices. With these heavy marketing efforts, it's plausible that people are not getting what they were sold. However, surveys tend to show people satisfied with their Advantage plan. These surveys are important in that they tell us that most people currently on Advantage are happy with it, but this doesn't tell us too much about Advantage for similar reasons that people choosing Advantage doesn't tell us too much. A. Advantage can offer very low premiums and extra benefits. It can do this so easily because the taxpayer pays considerably more per Advantage beneficiary compared to a similar traditional beneficiary. Of course, people like these extra benefits. However, we should give benefits because they are worth the cost, not haphazardly because private insurers have manipulated the government to get paid more than they were planned to. The point to Advantage was to find innovations and efficiencies in healthcare, not innovations in milking the taxpayer and sharing some of this milk with Advantage enrollees. Additionally, Advantage does provide insurance for people whose needed doctors and facilities happen to be in their network. It works great, and they get the benefits without the downsides. However, with insurance, you don't really know what you got until you need it. B. Many people checking positive boxes on surveys are not yet in need of their insurance, so have no basis with which to judge it. Insurance is something you need in a medical crisis, when your life is literally on the line and big financial bills can rack up. Will your insurance be there when you need it? Will it allow you to get the care you need for whatever problem arises for you? Most survey responders don't know the answer to this, and even if only a fairly small minority have major issues when it comes to Advantage covering their needed medical care, that's a huge impact on that small percentage of people, and surveys do not capture that. The downsides of Advantage plans don't really hit you until you have complex medical needs. So for most people, their Advantage plan is fine because they don't use it much. Additionally, roughly half of Advantage enrollees leave the plan they are on within 5 years, which seems to indicate they are not so satisfied. A big downside about thinking Advantage is great because it's cheap and may cover your current doctor is that when you have complex medical needs and Advantage is no longer great, you can't exactly just switch to traditional. You can switch to traditional, but in most states, you either won't be able to get a Medigap plan or a Medigap plan will be much more expensive. Medigap can ban you from signing up for it or charge more based on health after the first 6 months of a beneficiary turning 65, meaning once one is in Medicare Advantage, you are kind of stuck. You can always switch back to traditional Medicare without a Medigap plan, but if you want such supplemental benefits, you may not be allowed or premiums may be extra high for you. Several people have said that they enjoyed Advantage when they were younger and healthier, but once they got a chronic condition, they were paying a lot in copays and deductibles, and they felt stuck because they could no longer switch to traditional Medicare with a Medigap plan. Biden change. The Biden administration lowered the base payments to Advantage plans by an average 0.16%. This is a step in the right direction, but not sufficient to correct the overpayment issues with Medicare Advantage. Additionally, a 2023 rule tried to limit deceptive marketing and reduce unjustified prior authorization. Insurers game and avoid reforms. Unfortunately, making changes is tough. Not only are insurers good at adjusting to reforms, they are also good at avoiding reforms altogether. Companies get better over time at gaming a particular system, and they do it faster than the government can counter them. The government just doesn't have the incentives or freedom of movement to keep up with a profit-driven private sector. Some changes require a heavy bureaucratic lift to get through, which may be impossible if the current president is ideologically or financially in bed with insurance companies. And other changes required an act of Congress, who is loath to touch anything Medicare, which will be demagogued by their opponents. And congressmen, like a president, may be ideologically or financially opposed to challenging Medicare Advantage insurance companies. The very existence of Medicare Advantage can make traditional Medicare worse by facilitating Congress to not focus on improving traditional Medicare because they think people can always use Advantage. This is even worse for free market ideologues who see Advantage as the more free market alternative and want traditional Medicare to be as limited as possible to promote Advantage. Sometimes these politicians create a self-fulfilling prophecy whereby their belief in government failure makes them refuse to make necessary changes and adaptations to government programs, and then their failure to act makes the government program worse or even fail. Then they say, "See, government sucks," when it was their belief in this that caused them to not take basic actions to make the program work. It is ideologues like this who rightly have concerns about the government debt, but then do nothing to stop massive government overpayments to private companies like Medicare Advantage. Advantage was found by CMS to be abusing risk scores and getting overpaid, and CMS didn't do anything about it. Just to get this information to the public, CMS had to lose a 3-year battle against a Freedom of Information lawsuit. A couple other things to note. In the 1980s, the largest private Medicare contractor was International Medicare Centers. It collapsed in 1987, leaving $200 million worth of bills unpaid to providers. It spent a lot on administrators and lobbyists. Its president was accused of stealing $230 million from Medicare. He was indicted for bribery, conspiracy, and wiretapping, while also being accused of providing inadequate care and pressuring sick people to disenroll. He fled to Spain. Lots of researchers look at Advantage versus traditional, but Advantage is a bunch of different plans, and many are different from each other. So there is a lot of nuance not understood about how specific Advantage plans work compared to traditional and compared to each other.